Wow, we actually made it. Welcome back, everyone, to the grand finale of our Explainer series, Part 15. You've put in some serious hard work getting to this point, mastering everything from foundational codes all the way to complex modalities. But today is where we build an absolute fortress around all that effort. We're talking essential physical therapy modifiers, discharge planning, and, perhaps most importantly, audit-proof billing. Because let's be real, getting paid for your hard work is only half the battle, right? Keeping that revenue safe from clawbacks, that is the ultimate victory. So grab a coffee, get ready to take some notes because we are laying down the absolute ultimate defense strategy for your practice. So let me ask you a rather heavy question. Is your billing truly audit-proof? Audits and denials are basically the ultimate enemy of a healthy, thriving physical therapy practice. Think about it. You could deliver the absolute most life-changing, highly skilled clinical care in the world. But if your billing and documentation leave even a tiny crack in the door for an auditor to question your codes, well, that hard-earned revenue is instantly at risk. Our goal today is to slam that door completely shut. Okay, let's dive into this masterclass grand finale agenda. We're going to cover the ultimate audit defense, take a deep dive into Modifier 59, and unlock the secrets of the KX, GP, and GA modifiers. After that, we'll hit on some non-negotiable audit-proof documentation habits, and finally, we'll wrap up our series. Section 1, the ultimate audit defense, protecting your revenue. Because proper coding is absolutely not just about getting that initial paycheck, it's your best shield for keeping that revenue safe when post-payment audits inevitably come knocking. Moving right along to Section 2. Deep Dive, Modifier 59. This is the heavyweight champion of PT billing, so let's get into it. So the 59 modifier is absolutely critical when you provide two completely distinct services in the exact same treatment period. The National Correct Coding Initiative, or NCCI, essentially acts like a massive rulebook. They've identified specific procedures that therapists commonly perform together, and they've linked them as edit pairs. For example, if your primary build code is 97140 for manual therapy, the NCCI links this with several other codes. We're talking 97530 for therapeutic activities, 95851 for range of motion testing, or even 97018 for a paraffin bath. Here's the catch. If you bill 97140 alongside any of these linked codes without the correct modifier, you're basically just volunteering to get paid for the 97140 alone. That second code, it's going to get denied as inclusive. The crucial takeaway here is knowing exactly how to break that edit when it's appropriate. Let's ground this in a real-world clinical scenario. Imagine you're providing 15 minutes of manual therapy, code 97140, and then 15 minutes of therapeutic activities, code 97530, on the exact same date of service. Because they are an NCCI edit pair, billing them raw means you're literally leaving that therapeutic activities payment on the table. But by appending Modifier 59 to code 97530, you are formally indicating that both of these services were provided completely separately and independently. That tiny little modifier proves they are distinct, which means your practice qualifies for separate reimbursement for each procedure. It's a tiny detail, but it has massive revenue implications. Let's move to and see how this builds in Section 3, KX, GP, and GA modifiers. We are transitioning from distinct procedural services into the modifiers that dictate Medicare thresholds and coverage rules. First up in this group is Modifier KX. You use this one specifically for services provided after a patient exceeds Medicare's annual per beneficiary incurred expense threshold. Now, listen closely because this is a massive red flag for auditors. You can only use this modifier when you know with absolute certainty that continued treatment is medically necessary and it absolutely must be performed by a skilled therapist. Appending the KX modifier is literally a direct attestation of this medical necessity. You're basically signing your name and saying, hey, I have justified this necessity with rock-solid detailed documentation in the patient's medical record. If you throw a KX on a claim without that documentation, you are a sitting duck for an audit. Let's make this totally concrete with a threshold example. Say a patient comes in for a hip fracture early in the calendar year. They require extensive rehab, and they end up hitting that Medicare threshold pretty fast. But then, tragically, later in that exact same year, the patient suffers a cerebrovascular accident, a stroke. Now, they clearly require physical therapy well beyond that initial threshold amount, right? In this case, you'd apply the KX modifier to those new claims. It clearly justifies to Medicare that this continued care is absolutely not just routine maintenance, but a stark medical necessity due to a brand new CVA diagnosis. Next up, Modifier GP. Honestly, this one is pretty straightforward, but it's still heavily scrutinized. The GP modifier simply flags that the therapy services were specifically provided by a physical therapist. Now, you might be wondering, why is that even necessary? Well, in inpatient and outpatient multidisciplinary settings, patients see multiple types of providers all the time. You want to use a GP modifier in any situation where there could be even a shadow of a doubt about which provider delivered the services. Like if you're in a clinic where occupational or speech therapists are also billing, this modifier brings absolute, crystal clear clarity to the claim. Finally, for this group, let's look at modifier GA. This one indicates that a required advance beneficiary notice of non-coverage, an ABN, is actively on file for a service that Medicare does not consider medically necessary. This modifier is a real game changer for your practice. It legally empowers you to either bill a secondary insurance for those non-Medicare covered services, or it lets you bill the patient directly without violating a single Medicare rule. And this brilliantly illustrates how it works in a common maintenance scenario. Let's say you've been seeing a Medicare patient for 6 weeks post-op. They've done amazingly well, but now they've reached a functional plateau. Skilled rehabilitative therapy is just no longer medically necessary in the eyes of Medicare. But the patient loves coming in. They want to keep attending PT for ongoing maintenance. By getting an ABN signed and popping on that GA modifier, you're using the correct tool to either continue billing their secondary insurance or safely transition them to a direct pay model for that maintenance care. All right, Section 4, Audit-Proof Documentation Habits. Because here is the harsh reality. Every single modifier we just talked about is completely 100% useless if you don't have the clinical documentation to back it up. This contrast right here is a massive area of focus for auditors. They are actively hunting for a clear, undeniable separation in your notes between timed code treatment minutes and total treatment time. Timed code treatment minutes absolutely must reflect the exact minutes spent performing specific individual timed CPT interventions. Total treatment time, however, is the entire duration of the therapy session, so the whole shebang, including both those timed services and any untimed services. You've got to clearly document both of these distinct numbers to justify the exact units you are billing. If these numbers are muddy or just lumped together, an auditor will strike down that claim in a heartbeat. To wrap up the documentation piece, let's just rapid-fire summarize the top audit-proof habits you need to build into every single note, right up through your final discharge report. First, your notes have to vividly paint a picture of the patient's impairments and functional limitations. Tell their story. Second, always document the prior level of function, or PLOF. It establishes their potential and prognosis. Third, explicitly describe the highly skilled nature of the therapy provided. Why did they need you, a highly skilled professional, for this? Fourth, justify the frequency, duration, and the ongoing need for care. And lastly, it sounds silly, but it happens, never forget to include signatures and credentials on all reports. When discharge day comes, that final report has to include cumulative functional outcome measures and summarize the entire trajectory. You have to prove the ultimate value and necessity of that whole episode of care. Which brings us, incredibly, to Section 5, Series Wrap-Up and Grand Finale. We have reached the end of an absolutely incredible 15-part journey together. You've mastered everything from basic definitions and modalities to cracking the code on the 8-minute rule, navigating tricky NCCI edits, and building ironclad audit-proof strategies. Thank you so much for joining me on this deep dive into physical therapy coding and billing. It has been an absolute privilege guiding you through all this material. But as you step back into your clinic tomorrow, I want you to ask yourself one final thing. Is your documentation simply recording the past, or is it actively defending the future of your practice? Take these tools, apply them to your daily workflow, and watch your compliance and your revenue stabilize. Until next time, stay sharp, keep learning, and decode healthcare with Harshal.